property which promote growth of the human fibroblast and improve granulation tissue formations. But before we go and see where we stand today from the MDT, let's go back in history. The first time the MDT was used in World War I by Dr. William Pearl, but in World War II, the penicillin was discovered. And this has really put the MDT in outdated. Late in 1980, we started seeing the bacteria which resistant to antibiotic, and this really helped to resurface of the MDT. In January 2004, USA FDA granted permission for Maggot to be used by prescription only. And since 2006, we have about 50,000 treatments applied. And in 2007, University of Manchester used Maggot successfully to treat about 13 patients with MRSA-infected diabetic foot ulcer. Not all the spices are safe. The white flies can carry infection, so the only one we can use, which comes from the Monash labs, is the green bottle flies, which is tested for over 12 years. And this is tell you how safe is this maggot. It will grow from 2 to 8 millimeters in about 3-4 days, and they eat only the dead tissue and leave viable alone. It will not reproduce inside the wound. Because it takes about 3 weeks to mature. Will not burrow inside the wound because need air to breathe. This helps her to stay on the tissue surface, so it's very easy to be flushed out, and will not bite because it doesn't have any teeth. So maggot work like really a surgeon razor. It has a rough patches on the body and specialized mouth which help in the debridement. How we apply it? Usually the application takes about 15 to 30 minutes to apply it. It comes in two forms: free moving in the moving maggot, which require to do a cage dressing to trap it in place and prevent it going out of the wound, or come already contained in a sealed pouch. Usually leave it in the wound for about 2 to 4 days, and usually grow larger as they eat, and seek to leave the wound when there is no more dead tissue. The reason why we need to use a cage dressing or pouch. Usually we use about 2 to 4 cycle of treatment for each. This is how they come, the free-range larvae package. Usually you add saline to the tube which has the larvae, and then you pour them inside the wound. Then you put a mesh to cover it, and then you create the cage dressing to prevent the larvae from leaving the wound. And finally, you apply your bandages. The other form, they comes as a pouch dressings already sealed inside the pouch. You just put them in the wound followed with the dressing. What the indication? Usually you use it for chronic non-healing wound. This can include a pressure ulcer, venous stasis ulcer, neuropathic foot ulcer, and non-healing traumatic or post-surgical wound. It has a 3 primary action: debridement, disinfection, and healing. Let's talk about the debridement. Maggots usually are far more precise than human eye. It's better than surgeon because it leaves more living tissue than surgeon. Surgeon has tendency to be aggressive in the debridement. And also the proteolysis enzyme liquefied necrotic tissue and help more in debridement. Also the timing is very important because maggot work around the clock, whereas the surgeon limited by the anesthesia and work schedule. Disinfection, the antimicrobial secretion remove infection, including many antibiotic resistant bacteria like MRSA group A and group B streptococci, and bacteria are not likely not killed by the secretion, will be usually ingested and lysed by the maggots. Healing, also maggot secretion increase the healing effect of the epidermal growth factor interleukin 6, stimulate the growth of fibroblasts, chondrocytes, and cartilage-specific type 2 collagen, and contain allantoin, which soothes the skin. Also the micro massage of the wound bed, so to increase aggregation tissue formation and wound exudate, and healing often increase with the maggot application, but not all the time. This is very summarize the mechanism of wound healing by the maggot. As I said before, the maggot work in 3 ways. First, the excretion is excrete protease and DNAs, which help in debridement, release of antimicrobial peptides and DNAs, and this also help in disinfection, also help in production of allantoin and urea, which stimulate fibroblast proliferation and migration and angiogenesis. All this will increase perfusion to the wound, reduce inflammatory response, and reduce the complement C3 and C4, and this all help in the growth stimulation and wound healing. Also, the physical contact with the host, it helps in the debridement of the wound, and also it helps to ingest the bacteria, and this helps in disinfection, and as we said before, it helps in stimulation of the wound healing. This is one of the cases where a patient has a large wound venous ulcer which debrided surgically, but you can see still a lot of slough inside the wound. So Mucket was applied in the pouch, and this is after 4 application of the Mucket, and this is after 6 weeks of treatment. Another patient before and after Mucket treatment. So what the literature saying about the Mucket treatment? This is a very nice paper published by Dr. Sherman 2003. The purpose of this paper to examine the efficacy of MDT in treatment of diabetic foot and leg ulcer which have failed in conventional therapy. They have about 18 patients, and all of them they use a cage dressing. What they found that the Mucket therapy was associated with faster debridement and wound healing than conventional therapy, faster growth of granulation tissue, and a quicker decrease in the wound size, complete debridement in MDT patient after 4 weeks, and 50% reduction in the necrotic surface area after 9 days, when in conventional therapy it took about 29 days. So what they conclude that this study really supports the benefit of MDT as reported by earlier study to treat chronic wound ulcer. Another review done by Wag, 2010, and this one he looked at the efficacy of the Mucket treatment and infected wound. So he has 25 patients with diabetic foot ulcer and 18 with a partial ulcer, but all of them, they have a positive culture with antibiotic resistant bacteria. And he used 2 groups comparing the Mucket with the convention versus conventional therapy alone. And he found that all ulcers healed completely in both groups, but the process was significantly faster in MDT group comparing to the other group, and time to granulation tissue formation was cut in half for MDT versus traditional therapy, and culture was negative for antibiotic-resistant bacteria, and there was no occurrence of ulcer in MDT patient in about 2 to 6 months. So what he concluded, again, the MDT found to be a safe, effective alternative to traditional wound care. What about the venous ulcer? This is a very nice randomized controlled trial called the Venus 2. The objective of this paper to our trial is to compare the clinical effectiveness of larvae therapy with a standard debridement technique, which is hydrogel, for sloughy or necrotic venous leg ulcer. They have 267 patients with at least 1 venous ulcer or mixed venous and arterial ulcer. And they look at the time to ulcer healing after larva therapy. Comparing with the hydrogel, there was no difference in the time of the ulcer healing. But when they look at the time to debridement, it was much faster when you use a larva treatment than comparing with a hydrogel. So when they conclude that larva therapy did not improve the rate of healing of sloughing or necrotic leg ulcer or reduce the bacterial load comparing with a hydrogel, but did significantly reduce the time to debridement. Another also paper published 2014, also randomized controlled trial looking at the venous ulcer and treatment by using a Mucket. They have here about 600 patients with a chronic venous ulcer. They randomized into 2 groups. The first group, they have 4-layer compression bandage only. The other group, they have 4-layer compression bandage plus the larvae. And they have 12 weeks follow-up. And again, when they look at the sloughy tissue, there was a significant reduction in the sloughing tissue in the group who had larvae compared with the conventional therapy, but the healing process also was the same for both groups. So they conclude again that larval debridement therapy improved wound debridement in chronic venous leg ulcer treated with the multi-layer compression bandages. However, no subsequent improvement in the ulcer healing was demonstrated. Another paper looked at the Mucket debridement therapy treatment of non-healing chronic venous ulcer. This is a meta-analysis of 13 articles, and all of them they found the MDT help in the wound debridement. Also, it was effective in the wounds that are unresponsive to the conventional therapy, and also helped in save the limb. And the post-operative wound infection decreased significantly when you use an MDT, and also decreased the wound size faster and more effective than conventional therapy. So what they conclude that MDT again is an effective and successful method of healing of the wound healing, and the maggot therapy not only remove necrotic tissue but also work on this infection wound and responses to antibiotic. A maggot therapy could be considered as a first-line treatment for non-healing ulcer. So what are the pros and cons and limitations? The pros for the maggot, it's a literature-supported efficacy of treatment. We saw many literature support the using of the maggot. It is safe. It's a simple procedure. You don't need to have experience. You don't need a surgeon. It can be applied by the nurses. Inexpensive, efficient, and often successful in treatment wound which not respond to the more traditional treatment. The cons are highly perishable, so it has to be used within 24 hours of arrival. Some patients reported discomfort, but especially if they have an arterial wound, a maggot debridement not possible for all wounds. And idea is distasteful or creepy to some physician or patients. The contraindication, if it's allergic to adhesive or fly larvae, eggs or soybeans, patient with coagulation disorder, deep tunneling wound, active bioderma granulosa in the absence of the proper treatment, wound likely to communicate to the central venous system, nervous system, large blood vessel, body cavity or vital organs, in necrotizing fasciitis or cases gangrene or in sepsis. So in conclusion, maggot therapy is a safe and effective treatment for the wound. It has three broad actions, which is debridement, disinfection, hasten tissue growth. Based on the strength of the current evidence, MDT can be utilized as a first-line therapy in the treatment of chronic diabetic ulcer. And unfortunately, there is insufficient evidence to support the use of MDT in chronic venous or mixed venous and arterial lower extremity ulcer. And the reason because reporting the outcome of MDT is limited by the lack of the global acceptance standards. Thank you very much for listening, and thank you again, Prof. Ayman, for this invitation. Thank you.
Thank you, Samer, for this great presentation. Please stay with us a few minutes to start our discussion.
Ladies and gentlemen,
now I would like to introduce Professor Mark Whately. Professor Mark is going to discuss venous reflux management in 2050.
asked to be part of your conference today, and I'd like to thank Professor Fakhri for the very kind invitation. Today he's asked me to talk about venous reflux in 2050, which is an incredibly interesting and thought-provoking title. I really have had to think about this probably more than any talk I've given in the last year. So what is going to be the future of venous reflux in the year 2050? Well, of course, that's 27 years in the future, and so none of us know what the future holds, and especially in 27 years' time. So the first question really was how to approach this. I was a teenager in the 1970s before I went to medical school. One of my favourite programs was Space 1999. And this program predicted that by 1999, which was approximately 27 years hence from that time, we would have colonized the moon. And the whole thing revolved around this colony on the moon. And at that stage, we all believed truly that in 1999, this would be a realistic possibility. This brings me to the first point. Things really change slower than you think they're going to. However, not everything changes at the same rate, and progress is certainly not linear. And we've seen in the past that over the hundreds and hundreds of years, little changed. And over more recent years, there's been an increasingly acceleration of the progress of technologies, and certainly bits of technology, if not all of technology. So let's look at the past. What can we learn from 27 years ago to now, and see if that helps us predict, knowing that it's not linear, what we're going to see in the future. Technology doesn't grow in a linear way, and we know the first mobile phones were huge when they came out in 1985. But 27 years ago, we had quite a sophisticated device, the Nokia device, that you could both make telephone calls on and text. However, 27 years later, we now have these mobile phones, which we all know are really mini computers. And the computing power within these mobile phones now was almost unthinkable 27 years ago. However, what do we need it for? And the reality is, although it has huge technological advantages, what we need it for as humans hasn't really changed an awful lot, apart from browsing the internet and looking at videos. When it comes to the diagnosis of venous reflux, of course, back 30 years ago or more, we used to use Perthes test and the tourniquet tests, handheld Doppler, descending phlebography. But when we look at 27 years ago, which is the point of this talk, we already had colour flow venous duplex ultrasound. Now, of course, the new machines, although they're based on the same technology, are far better. The probes and the resolution give us far better images, and we can now do three-dimensional scanning, elastography, and there's all sorts of new things we can do. But essentially, although the technology is improved, the actual underlying basic physics is very similar. Of course, one of the areas that has rapidly changed in the last 27 years is the actual treatments that we perform. So in 1996, most of us were still doing high ties and stripping, and certainly nobody was doing endovenous surgery unless we were talking about just simple liquid sclerotherapy. However, nowadays, the majority of us are using endovenous thermal ablation techniques such as the laser or the radiofrequency, and using ultrasound-guided foam sclerotherapy such as shown here by the Vrixio machine. Now, of course, we already know that in the last few years, the non-invasive high-intensity focused ultrasound machine, the Sonovane here, has been starting to make an appearance, although it's not anywhere near mainstream treatments yet. So really, when we're talking about mainstream treatments at the moment, we're really talking about the endovenous thermal ablation and ultrasound-guided foam techniques. So having looked back 27 years, now let's look forward 27 years, and we're going to look, as in the title, to 2050. It's clearly impossible to accurately predict what we're going to find then, because, to paraphrase Donald Rumsfeld, there are things we know, and that's obviously what we make our predictions on. There are things we know we don't know, and we can sort of guess because we know we don't know these things are coming, but we hope they're going to. But what really mucks things up is the things we don't know we don't know. These are the new technologies that come, the way things might change with either conflicts or climate change or materials. There are so many things that might happen that we really can't put our finger on at the moment, and this is why no predictions can be absolutely certain. So I'm going to make some guesses using the things we know and the things we know we don't know. Put some of those really weird and wacky ideas out there. Firstly, will human veins still reflux in 2050? We know from the work from Oliver Lyons and lots of other very clever scientists in the vascular field, we know that there are genetic causes for valves to either fail or to fail to form in the first place. And so having identified some of the genes responsible for valve failure or valve malformation, is it possible to correct these genetic causes either using CRISPR or other gene modifying techniques or drugs? Can we actually change the genetic structure so that the veins stay competent and don't become incompetent? Of course, that's a dream, but it's highly unlikely, certainly within 27 years. We know that there's over 100,000 processes in every human that is controlled directly from the genetics, but the Human Genome Project showed that when the human genome was actually mapped, there were only 22,000 genes. Therefore, most genes have multiple functions, which means if you start dealing with one gene because you want to change one of its functions, on average, you're going to adversely affect, or certainly affect, 4 other functions. And because of the huge interconnectivity between the genetic functions, you may end up with a severe problem that you couldn't predict at all. So I think it's highly unlikely that within 27 years we're going to be able to find out all the pros and cons of changing any genetics on something as simple as valve failure in superficial veins. It's not strictly related just to veins. I think we should also just look at what's happening in the world at the moment. There's a decreasing birth rate, and although people think that the population is expanding, it's only expanding because people are living longer. There's approximately 1.6 reproductive rate at the moment, which means each couple produce only 1.6 offspring. So we have a decreasing number of young people, which means we have a decreasing young workforce and an increasing age of population. And this means that in all countries we're now starting to have problems with reduced numbers in healthcare compared to those who require healthcare. Therefore, without doubt, we need automation. If we're still using ultrasound, this is going to have to be based on robotic and artificial intelligence, because we won't be able to sit there and do all the scans we need to. And therefore, we need wearable technology and monitoring. Possible, we need to move on from duplex. We don't want just images and flow, but we need to know function. And we need a test that's not operator dependent, it's reproducible so we can show other people the results, and is automated and fast. Reflux is a deterioration of cells and tissues, and therefore unless we can actually regenerate cells and tissues, we're not going to be able to make a primary repair likely. And of course that's probably not going to be looked on favourably ethically, because it could lead to immortality. And it's unlikely that within the next 27 years we're going to have either prosthetic or genetically engineered valves that can be implanted into superficial veins. Very beloved of science fiction and already in use in certain areas, it's unlikely, I think, that nanobots will be injectable into the body and be able to repair these great big structures of deteriorating valves compared to the size of the nanobots, and safely then effect the repair and be removed within 27 years. Therefore, if we can't prevent the veins from refluxing and we can't repair them primarily, therefore we have to go back to the thought of ablation, which is of course what we've thought about for the last 120 years. The latest thing in ablation, as we know, is high intensity focused ultrasound, and as it's non-invasive and also non-ionizing and there's no radiation, it looks like the best bet to be something that can be perfected. The technique can be automated, and because it uses ultrasound, it can also not only recognize veins but also recognize incompetence. My best guess is that we will have wearable technology that will suggest we have venous reflux. We'll go to a coffee shop because all other shops will be closed because everything else will be delivered to you at home. You'll pay by electronic transfer. You'll put your leg into a robotic device or a box, inside which robotic device will measure your venous reflux, will identify your veins, and will ablate them with high intensity focused ultrasound. You'll have your coffee and then go home.
Thank you, Mark, for this very nice presentation, and thank you for traveling with us through the future. I know I have a scheduled case in a couple of minutes.
Been stuck in there.
So I'd like to start make questions. I will take the advantage to start my question. Do you think in the future treatment could be self-managed, that robotic surgery, robotic diagnosis? Could we extend our hopes that it could be done by the patient himself? Self-management of his varicose veins?
I think that's probably going to come down to economics, because I think the artificial intelligence that we're seeing and the actual machinery will be able to be working probably autonomously, which means that you can probably be able to have it brought round to your house in a truck in the first instance. But if it gets small enough and it gets cheap enough, then yes, it could be self-managed. I think if it's going to be a one-off treatment, though, certainly in 27 years, you gave me the title for the 2050, I think it's probably that these will be too expensive, too big, and they'll be shared, and therefore you'll probably go somewhere or they'll be brought to your home. But you're quite right, in the future, there's no reason at all why these shouldn't be miniaturized and cheap enough to do by yourself.
Questions for Mark? Please, Dr. Khaled.
Dr. Dr. Watley, for this marvelous presentation. I want to ask a question. Is there will be a venous disease in the future? Maybe it will be prevented by genetic therapy and treatment of the causes genetically. So we will have no venous disease in the future. Do you agree with me, or?
I think it's highly unlikely. As I said in the talk, I showed the slide. The difficulty is, if we look at all the cancer work that was done in the 70s and 80s, we all thought there would be a magic bullet. We thought we'd find one gene, maybe one that arose from a virus, the oncogenes, and if we could block that gene, we could stop cancer. And what we found instead is that when we blocked the one gene that caused the cancer, we made things worse. The metastases got worse. The patients died quicker. And what we've found is that the genetics are much more complex than we think. There's very, very few genes that have just one function, like hair color or eye color or blood group. And when you start playing with one gene, you then start having ramifications that you can't predict. Maybe not even in your lifetime, but maybe in your children afterwards. So I think, in the fullness of time, it's quite true that we might understand epigenetics and genetics enough to do something like that. I don't think it'll be within 27 years. I think that I think it's unlikely, even if that's working for certain malignancies and big cases. I certainly don't think it'll be in structural changes of deterioration such as arthritis and venous disease. I may well be wrong. As I said before, we don't know. But when we look back to see the progression in each quarter century, I think it's unlikely we'll be able to get that complexity within that time.
Yes, please, Dr. Hisham.
Thank you, Mark, for this nice presentation for the future of venous disease. But I may extend my question to use of the stem cell therapy and its improvement in generation of specified cells to treat the venous ulceration especially. Is that in the near future can treat the venous ulcers as well?
Yeah, it's fascinating, isn't it? The question is, with the ulcers, we've got C6 disease, so we've got one end, and what we've done is we've let the whole venous system deteriorate so much that we've now got the fascial cutaneous damage. And I think if we're talking about the future and we're really thinking about, how things are going to progress, we want to be changing things at the beginning when you get your first reflux, so you prevent the ulcers. But in the meantime, you're quite right. I think stem cell therapy is a very interesting area for regeneration of skin. But of course, remember what caused the ulcer in the first place. There's no point in treating an ulcer if you don't correct the underlying problem. So we still have that thing. We have to take away the venous reflux or obstruction or stasis, whatever it is that caused the ulcer first. Get rid of that first and then concentrate on curing the ulcer on the surface, because then you're fighting something you're going to win.
Thank you, Mark. I admire very much being with us today, and thank you for coming. And now we can join your patients. Thank you very much. And please, let's have you within the next 2 months here in Cairo. Please mark your calendar.
I'd like to join you there.
Okay, Mark. Thank you very much.
Thank you. Bye-bye.
Thank you. Now I would like to introduce Professor Sergio Janisi, Professor of Lymphology, Freire University. He is the President of VUN Foundation and the elect President of UIP. Sergio will discuss, can hydrotherapy help in venous ulcer?
Dear friends and colleagues, if you're listening to this recording, it means that the day was unlucky in the operating room and I have been stuck in there. I'd like to deeply thank all the Egyptian Venous Forum representatives, in particular Professor Ayman Fakhri, for this scientific time travel in which I've been asked if hydrotherapy in the future could help for venous ulcer management. The reason why Ayman asked me this very probably is because he knows I'm particularly interested with a research project called the Science Per Aquam, in the proper use of the aquatic environment. Now, the aquatic environment is pleasant per se, according to the Global Spa and Wellness Summit. A lot of people are going to the aquatic centers. As you can see, there are indeed a lot of investments in this sector, but at the same time, there is not that much investment in terms of science in the venous and lymphatic field. Indeed, our colleagues from the musculoskeletal system management, so physiotherapy, rehab, physiatrists, have been producing a lot of literature, while us, as vascular experts, have not produced that much, and mainly in terms of quality of life. But of course, it doesn't require that much scientific drive, understanding that going to the aquatic environment is a pleasant experience so that the quality of life can improve. In Italy, we see a lot this phenomenon of people going into these pools, walking in cold and hot water, with the idea that this will be extremely beneficial for the legs. When in reality, there is, up to our knowledge, no data, so we are working in collecting also in this sector. Because in the past, there were indeed interesting investigations like the one of Ernst that was showing at the time of the cassette, so we go back in time, the potential benefit of this not standardized walk in terms of volume and some hemodynamics parameter. Very few ones, to be honest. And a few years later, in the time of the CDs, so Keep On Traveling, Carpentier did very interesting investigations with a crossover trial, also looking at the leg pain control inside and outside the pool. But the problem for both of these investigations is that there was no standardization and no reproducibility. As we know in science, we have to standardize what we do and we have to make it reproducible. And the type of balneotherapy, as you can quote unquote indeed read in the different papers, was chosen by the physician for each and every single patient, so there was variability. A constant is the gravitational constant, and if you consider the constant of the density of the fluid, then we have just the hydrostatic column as a variable in the Stevin law. That is the one that is creating the pressure when we are standing up inside the pool, for which every single centimeter of water becomes a 0.7 millimeter mercury, which means that when we are at 120 centimeter depth standing up in the pool, we have more than 80 millimeter mercury, which means 4 pairs of stockings, if you think about that. That's why in 2017 we published the, up to our knowledge, first aquatic protocol that was standardized and reproducible and assessed in a rigorous way, showcasing in 32 lower limbs of fallible lymphedema what was going on in terms of lower limb volume decrease after 5 sessions of 15 minutes each twice a week. Significant decrease in lower limb volume of more than 300 mils, with decrease of the different circumferences along the leg and also subcutaneous thickness measurement. Ankle range of motion significantly increased with the correlation with the lower limb volume, highlighting the role of the ankle pump, for which you see there Michael Jackson walking backward, because indeed there is also the backward walk inside the protocol. VAS demonstrated an improvement in terms of heaviness perceived by the patients in a significant way, while the functional ambulation classification did not change significantly, considering also that we had just 5 sessions. This could be a matter of debate. But the bigger debate topic could be the role of the exercise versus the role of the aquatic environment. Was it the exercise? Was it the aquatic environment making this benefit for the patients? And that's why we started a very rigorous randomized comparative trial called the DATA study, Dryland and Thermal Aquatic Environment Investigation, that is now included as the only randomized comparative trial in this recent systematic review, with also a very low risk of bias. Same thing for the report of the Cochrane that you see here with our investigation. The protocol is the same of the previous investigation, that is activating basically all the different joints of the lower limb, demonstrated that in the aquatic environment and not outside the aquatic environment, we have a significant control of the volume. We have a significant decrease of the subcutaneous tissue in the assessment points you see reported over here. of the GSV caliber, which means absolutely nothing in my opinion, because of course we should analyze all the different sectors of the superficial and deep venous system. And Michael Jackson over there, once again, showcasing that in this case, both inside and outside the pool, we have an improvement of the ankle range of motion, so the importance of moving, of course, our patients' joints, but at the same time, greater in the aquatic environment group. The correlation was, of course, only with the group in the aquatic environment that showcased an improvement, while the quality of life interestingly improved in both groups if we look at the CIVIC. If we look at the Vivim CQ, it was better in the aquatic environment with no significant improvement outside the aquatic environment. That tells us the importance of always looking with the different outcome measures in terms also of quality of life. In another publication on the topic, we focused on the bioimpedance analysis, showcasing the significant decrease of extracellular fluids in the aquatic environment, and correlated once again with the lower limb volume as it was for the ankle range of motion in the previous investigation that is in JBS. Another publication we did was on the cardiovascular effects of this protocol that demonstrated to be positive from a cardiovascular perspective, because there was a better control of the pressure and a decrease of the heart rate, for which we can suggest it also for the general fitness of our patients. This topic is included in the ViewInter 2019 document about similarities and controversies in different guidelines, because of course it should be taken more into consideration. And if we look at the question of Ayman for the future, well, we should remember that we put in that publication, like the fact that if we use compression after an answer yield, we have a significant decrease of the recurrence up to 9 times. So if we look at the future, and if we have to answer to this question, we can also look back at the past, because if you go back in 1998, there is also a very interesting similar publication in 1975. In pressure ulcer, there was already a benefit in the group using compression plus whirlpool rather than just compression. And in this sense, we can absolutely consider the rotational gradient and the hydrostatic gradient that is created as a potential benefit. Of course, we have to collect data. There are pools that are dedicated to single users, for which also with answer patients, we already put down the study design to do this. Of course, it is a little bit more cumbersome, but it is feasible. The topic was included also in the recently published ViewInter 2022 document in International Angiology. It's a 100 pages document, including also many Egyptian friends and colleagues who we deeply thank for having been with us during the Universal Expo, and also with the recognition of the United Nations, for which I think this is a very important call to reach out also to your patients, because the publication is associated with the booklets that are summing up the publication for professionals, with booklets dedicated to the patients in layman's terms in different languages, available in the Viewing Foundation website, where you can also report eventually encountered misinformation, including the ones on aquatic exercises or activities that have not really been validated for venous and lymphatic patients. I take this chance to invite you to take a vital step forwards during Vitally, that is coming in 2 weeks in Italy, in this private island near Venice, where you are all invited to join in person or online for free, where we'll discuss about what is vital we know of the current literature and what is vital we develop as new research lines, including also the aquatic environment, for which we created with the University of Ferrara a dedicated project called Science per Aquam that is available for everyone in case you're interested. As representative of the UAEP, I also have the honor of inviting you to get active with this organization that literally started with you, for which during my presidency, rest assured that the doors will be always fully opened. With this, I deeply thank you once again, and I remain at your disposal at my email, so I ask the organizer to send it to all of you so that you can eventually make comments and questions if you want. Thank you so much. Ciao.
Thank you, Sergio. I appreciate your time. You know, you are in the operating room now. Thank you very much for joining us. It will be very nice to send your questions. Now I will ask my friends to give question to Professor Samer. He was talking about the maggot therapy. Samer, are you still with us?
Yes, I'm here, Ayman.
Okay, thanks, Samer. في حد عنده أسئلة للدكتور سامر؟ تفضل يا بيه، دكتور هشام.
Thank you, Samer, for this nice presentation. Hisham Sharaf asking you about, do you think for maggot therapy in this era of improvement of different autolytic dressing and hydrogels for venous ulcers, do you recommend to use maggot therapy in this era?
Not really. As you said, now we advanced so much with the wound care, So really hardly now we need to use them, They're still available. The last time I used it when I was in the States, I talking about like maybe 15 years ago. But now I don't use them because, as I said, we are so advanced now with the wound care and the products, so really need to be done, But in some rural area, when the expenses are an issue, I think it still can be done, and used.
Dr. Nasser, please.
Good evening, Dr. Samer. As usual, you are talking to us a very interesting topic, but at this moment, I just wonder about the compliance of doctor and the patient to have this type of treatment from your point of view. What's the compliance of doctor? I mean, to make it simple, what is the last time you used maggot to treat venous ulcers? And in spite, I know it is effective, simple, non-toxic, but for my own interest, actually, I would like to know what the last case you use it. Thank you.
It's been about 15 years ago in our centers. We used to use it. But the problem, again, the idea sometimes is not acceptable by the patients, not only the physician, Just the idea for the patient is not acceptable. So really, I don't think at these days it has really a major role. And you can see all the studies show really does not affect the outcome. It just speeds up the debridement process, but it does not change the outcome from any regular dressing we use it now. So again, I think in these days, I don't think we have a major rule for maggot except for the cost in some maybe rural area.
Thank you, Samer. And I ask you if you still have a time, please stay with us.
Okay, no problems.
Okay, it's my pleasure to introduce the final speaker in this session. And now we have Dr. Ayman Fakhri discussing the genetic basis for venous ulcer prevention. Dr. Ayman.
I'm very happy to start my talk today, and I would like to thank my dear friends in Azhar Dumyat for inviting me and giving me the chance to be here with you today. And I'm fortunate because Mark started thinking about the genetic therapy and how the genetics could help in treating or even prevention of venous disease. Let us see how we can talk today about this subject. Future of genetic therapy for chronic venous ulcer prevention. I don't have any potential conflict. First of all, the genetic contribution to varicose veins. If there's association between venous disease and genetic sequence, we have to answer these three questions. Can genetic engineering improve the chronic venous disease? Now let's discuss what's the varicose vein pathogenesis, change that affect the development of varicose veins. we have these 4 components: valvular incompetence, increased venous hydrostatic pressure, alternation in smooth muscle cell arrangement, and changes in extracellular matrix and its component. Chronic venous disease run in families. The exact nature of genetic basis for this association is, however, far from clear. A genome-wide association study should therefore be considered to help further our understanding for genetic basis of venous disease. Hereditary family analysis through family studies showed the risk of developing varicose veins was 90% for children when both parents had varicose veins, and 25% for men and 62% for women, and when one partner or one parent was affected, and 20% when either parent was affected. This suggested an autosomal dominant inheritance with variable degrees. This is number 1. A variant of the FOXC2 gene and differential expression of human troponism 4 and cDNA was linked to genetic predisposition to the development of varicose veins. This is clear sequence. Again, gene expression studies revealed FOXC2 was the first gene described in which mutation were strongly associated with primary venous valve failure in both superficial and deep veins of the lower limb. Again, the C677T methyl tetrahydrofluorate reductase functional polymorphism was now seen linked to the development of varicose veins. This is number 2. This is another gene sequence. What about the venous ulcer? Yes. The hemochromatosis gene C282Y mutation and its association with venous leg ulcer based on the knowledge that chronic venous disease leads to local iron overload in the area of skin changes in the affected leg. The second question, can genetic engineering improve the venous chronic venous disease? Gene therapy seeks to alter genes to correct genetic defects and thus prevent or cure genetic disease. Let's see how this may help. Matrix metalloproteinases MMP1 is integrated in varicose veins. The regional varicose veins or the variation of the MMP1 and MMP13 diagnose in diseased varicose veins and low phenotype enzymes when compared to varicose veins of the upper segment. You see this alternation of these enzymes and its effect on the matrix will help in the development of varicose veins. So if we improve or prevent this association, we could prevent varicose veins or even improve varicose veins. Vascular endothelial growth factor, VEGF-G, elevation of vascular endothelial growth factor, and 2 receptors were found in varicose veins. If we deal with these receptors, we can prevent the action of this material. So, could chronic venous disease be genetically preventable? Could be. Genetic engineering aims to modify the genes to enhance the compatibility of organisms beyond what's normal. If we change this sequence or alter its action, we can either prevent or treat varicose veins. Let us imagine which is more important. Build our research on ablating varicose veins or prevent its development. Think about it. To conclude, Mr. Chairman, not only gene association studies clarify varicose veins development, yet it may help in both improvement and even prevention of this disease. Before I go, I would like to invite you all to the 10th International Congress of Egyptian Venous Forum in 2022, July 2023, in Zagazig University and in Cairo,